to the Fit and Fabulous podcast with Dr. Jamie Seaman.
Hello, everybody. It's Dr. Jamie, and welcome back to the Fit and Fabulous podcast. It is so wonderful to have you here with us today because we are going to talk about a topic that is getting all of the buzz in the media and online and in my clinic. And we are going to be talking about perimenopause and menopause and this transition and strategies that you can do in your life to make this a little bit easier on yourself and to optimize your health. Okay, so we're going to dive into it, but I want to introduce you to my guests today. I have Maria Claps and Kristin Johnson with me here on the Fit and Fabulous podcast. They are the co-founders of the women's health and hormone education practice called Wise and Well, and you can go find them on Instagram. That's how I found them. But Kristin Johnson is a board-certified holistic nutritionist through the National Association of Nutrition Professionals. She works as a functional nutritional therapy practitioner and is a recovering corporate attorney. I love that, the way you say that. Maria Claps is a certified health coach through the Institute for Integrative Nutrition and is a functional diagnostic nutrition practitioner. Together, Kristin and Maria have developed a deep specialty in perimenopause and menopause health through their clinical mentorships with multiple medical doctors and naturopaths specializing in hormone replacement therapy. In addition, they both completed advanced training in various functional testing modalities, which they actively use in their robust clinical practice, educating and helping midlife women. Kristin and Maria are also the co-creators of professional training program for other midlife women's health practitioners. In addition to their busy client work and peer mentorship program, Kristin and Maria serve as faculty lecturers for the Women's Hormone Network, which is a nonprofit comprised of medical professionals dedicated to advancing the most accurate, scientific, and medically advanced information on women's hormone health. They also lecture frequently at women's health summits, retreats, as well as appearing on a wide variety of podcasts. Kristin and Maria, welcome to the Fit and Fabulous podcast.
Thank you.
Okay, so we're just going to dive right in.
Let's do it.
You guys have a book coming out, or maybe it came out, depending on when you're listening to this podcast. But tell me where your passion for perimenopause and menopause, I mean, you lived in the world of nutrition, but why has this become such an important topic for both of you?
Personal need that started at age 43. And 43 was just sort of like a time when I was changing and I was like, oh, something is not quite right. I wasn't sure if I could identify it as perimenopause, but that's what it was. And I saw a doctor in New York City. It wasn't a horrible experience. It was an incomplete experience. And if it gives you any idea of when I went to go visit him, and it was in Manhattan and it was on December 26th in New York City. It's a crazy time. You can't hail a cab. It's really busy. So I walk into the office. I, have a battery of tests. It was a lot, but I was there for it. I was like fine with it. But at 43, he started me on estradiol and progesterone, a lot of supplements, and Klonopin as well, which I got a little bit addicted to. Thankfully, I was able to wean off that before it became really, problematic. I wasn't, even right now, I'm not necessarily against women starting HRT whenever they need it. And I probably could have benefited from it, but I went off because I didn't know what I was doing. Why was I taking this? I was confused. I was like, why do I need this? No one gave me any education on my changing body. And so I just ditched it. So I guess I didn't feel that much benefit from it at that time. In retrospect, I look back and I think I probably should have started HRT at around 45, considering that I was fully menopausal it was like between 47 and 48. So it was that at that point, I just sought more education and mentorship. But I was like, there's got to be a better way. I need to know more.
Incredible. Kristin, how about you?
Yeah, same time of life, but totally different experience. So I was living in Boston at the time, unbelievable home of big medicine, which is great if you have a disease or acute illness, but they weren't necessarily worried about kind of the, 40-something-year-old woman who came in and said, I don't feel right. Something's off. And for me, I didn't have cycle changes to observe because I was on an IUD. retrospect, wish I'd never done it, but we are where we are at any given time of life. My mom had gone through surgical menopause at 32. So I had not lived through her experience and, really had no genetic sort of timing to target as to when I might go through menopause. So it was the furthest thing from my mind, to be perfectly honest. And for me, the pain that was palpable was truly just not being able to perform. Consider myself a pretty type A, high performing woman, corporate attorney, raising 3 kids, rowing at the national and world level competitively. And I couldn't do any of it well. And I was struggling. And that I just knew that wasn't me. Something was wrong. And so I went into my doctor and I adored her and trusted her. And I'm like, something's off. And she said, no, nothing's off. This is just this time of life. And I'm like, no, like really, I can't get through my day without a list. I'm not sleeping. I feel like my world is constantly, shaking beneath my feet. And I thought, is it mold? Could it be Lyme disease? Maybe I have an autoimmune disorder. I begged her to give me tests. She refused to give me any tests, unlike Maria getting all the tests. And then I finally said, maybe it's my hormones. And she's like, it's definitely not your hormones. You're too young, and dismissed me. And to be perfectly honest, I got a little pissed. And I was like, no, something else is going on here. And I was, same thing as Maria, decided to get some more information, put myself back in school, really leaned hard into the low-hanging fruit of nutrition and lifestyle, thinking like maybe I personally was doing something wrong in all of this. And then started to realize that all the women I was working with kind of resembled me. They're at the same time of life. They have similar complaints. And I'm like, okay, wait a minute. It might be something else going on. And that's when the dive into hormones started. And ultimately, Maria and I found each other because she was offering a training on some testing. And we were both kind of wound up over this. We're like, look, no one's talking about this. Women are being gaslit. There has to be more to the story. And that's where we started seeking out and literally paying doctors to work with them and shadow them and learn from them and start to be able to develop some sort of, language that women could understand as to what was happening. Because I think we blame ourselves a lot during this time of life. And we just kind of wanted to end that.
Yeah. I mean, I see women all day long, who come in and sometimes they can't even put their finger on what the symptom is. They're just like, I don't feel like myself. Like there's something wrong. And I think for many years, gaslighting was real. It's like, well, maybe you're just depressed. Your kids are leaving to go to college and, this and that and the other. And yeah, you might run a battery of tests. Well, these all look pretty good. I don't know. There's, nothing wrong with you. Where I became really passionate about it, in our medical training, and this will not be a surprise to you, but I'm giving this for the benefit of our listeners. But in our medical training, where I trained at the University of Nebraska, we really didn't get a lot of menopause training. And a lot of it is because for 20 to 30 years, and we can go through WHI and all these things and the reasons why we're in the state that we are. But many of the practitioners that were training me were basically like, hey, listen, hormones are just for hot flashes. They should only take them for a short period of time. And that's it, and so that was like the training I got. Then I got in the real world, and I'm in private practice. So I'm my own, I'm my own boss, and I definitely have, older docs and mentors in my practice, but it just didn't seem like, anybody really had like a good solution for these patients. Well, my own mother, throughout all of this, had a hysterectomy. So she really wasn't 100% sure when she went through menopause, but here she is now in her 60s, and now she's 70. And she has osteopenia, horrible heart disease. She was never offered, hormone replacement therapy. I can tell there's, a little bit of mild cognitive decline. And, she's got all these issues now. And I'm sitting here thinking to myself, and she does have, metabolic issues. She's got prediabetes. She's been on statins since statins were invented, but her coronary calcium is still like off the charts. And so not just menopause, but just metabolic health in general. I just feel like my mom was done such a disservice, in the last 20, 30, 40 years of her life. Like what, if we would have done something when she was 40, gosh, we could just be at like a totally different place now when she's 70. And so, of course, seeing the mirror and the writing on the wall, I am my mother's daughter. I've become so passionate about, doing something different and really taking a preventative approach. And I think that the treatment of perimenopause and menopause is just that. It is a way to mitigate risk of chronic disease and to improve longevity and improve aging. And just this week, I was looking at this new study, and they were looking at all these different biomarkers in aging, because we think it's kind of just this gradual effect. I'm sure you guys saw it on social media, and they basically said there was 2 time points where there's this burst of aging within our cells and our bodies. And one of them was 44. And it's like, okay, well, no wonder, like, you know, even maybe if it's not their hormones, maybe their hormones look good at that moment, you know, this like burst of aging. And so although some people may say, well, it's just a natural process. And some women say this to me, I'd love to hear your opinions on this. You know, the over medicalization of menopause. So I would love for you guys to dive into that. You know, is treatment with hormones and things like that for everybody, and touch too on menopause as a business, because Forbes is saying that menopause is the new $1 billion business. So
you're poking a hornet's nest, Jamie.
Oh, come on.
Yeah.
You know, I just make money off pharma. I'm just
I know, yeah.
Pharma, so
Grifter.
send my paycheck too. Yeah.
Yeah, I'm all in favor of even running the risk of you as a physician coming across like you're over medicalizing menopause. Are you surprised that I'm saying that as a consumer? I want doctors to treat menopause. I think that is one place that is severely lacking. Of course, I do not feel the same thing about metabolic disease in terms of like the statins that you mentioned and, you know, the way most doctors look at cholesterol, but like I want doctors to take menopause more seriously. And I'm kind of like, yeah, let's medicalize it. If that means getting women on HRT, like then let's do it, because it is absolutely a time period in life where, you know, we need our hormones just as much. I'm sure you and many of your colleagues would take it seriously if a woman in her 20s or 30s completely lost her hormone sufficiency. So why are we not concerned for a woman who's 51 and who has lost her hormone sufficiency? So, you know, I get where people come from. I was a natural girl. I had three babies at home with a midwife, and I had one baby in a hospital with an OBGYN, and, you know, breastfed them and made their own food and, you know, raised them as natural as possible. So people are always surprised. Well, like, oh, well, why wouldn't you want to do menopause natural? And Kristin, what's the problem with doing menopause natural?
That's an early death, ladies. That is an early and uncomfortable death. Yeah. Yeah. And I think the people who push back on the medicalization are kind of unknowingly or maybe intentionally leaning into some of the kind of social political things around menopause. Like, oh, you know, it's saying that menopausal women are deficient in something. It's like, well, we are. I don't think diabetics are getting really all up in the arms if they're deficient in insulin, right? I mean, that it is a state of deficiency, and it doesn't mean you as a human.
If your thyroid's not working, nobody bats an eye at giving people thyroid replacement.
Exactly.
Like maybe that was just nature. Maybe
Right. So it's, you know, there's this pushback against deficiency. There's a pushback against menopause generally because women perceive it as a time where they're irrelevant, which is not true. No one's saying that. It's, you know, if you want to wrap everything up in fertility and menstrual cycles and say you're a woman with them and not a, you know, relevant woman without them, you can do that, but that's not what is truth. And that's not what anyone's saying here. And I think, you know, people want to debate this whole lifespan issue, but the fact is in the 1900s, the woman's lifespan was much shorter than it is today. And we weren't living out, you know, past our menopausal years. And yet, even then, when we were talking about 5-6 years past menopause as the typical lifespan, it was recognized as a state of medical risk for chronic diseases. And every major medical society in the world accepted hormone replacement as a disease prevention intervention. So, you know, why we got from that to this is a bit of a convoluted discussion, but it has to do with, you know, pharmaceutical capture and some bad studies and a whole bunch of other things. But why today, like Maria said, if a 31-year-old with amenorrhea, or let's say has to have her ovaries removed, I believe the standard of care is pretty much slap a patch on her before she comes out of the OR because we want to protect her body, even if she doesn't want kids, right? Even if she's happy to not have a menstrual cycle any longer. We recognize that loss of hormones is a disease risk for the younger woman. Why are we fighting recognizing that same thing for the older woman? And, you know, I just kind of tell women, like, be careful sometimes who you're consuming your information from, because a lot of times there are these social political threads being woven into their position.
Yeah, I do believe in my heart of hearts that most doctors want to do the right thing for patients, but I have seen women in my practice who have had one that had a complicated C-section that required removal of her ovaries, and she was given birth control pills as replacement. I've seen women in their 40s who have gone through an elective hysterectomy for a variety of reasons, endometriosis, fibroids, whatever, had their ovaries removed and were given, offered nothing, or once again given. I mean, it's just, we can do so much better for these patients. And I stomp my feet a lot too in women's health, comparing our world to men's health. You can say, well, it is natural because 100% of women go through menopause, but 100% of men go through andropause, and we don't bat an eye giving them testosterone replacement and Viagra and Cialis and BPH meds. And I mean, it's just like, and not even just that, but if you guys saw my world of writing prescriptions for hormone replacement therapy, the coverage for women is like atrocious. The money that some of these women have to pay even just to pursue, hormone replacement therapy. And so, oh my gosh, it's just, yeah, I could I could get worked up over it, but let's dive into what people want to hear about. Okay, can one of you kind of give me like the kindergarten level? How do I know if I'm in perimenopause or menopause, and what might be signs or symptoms that I might be experiencing?
Okay, so it doesn't always come with symptoms. Feedback here. But some of the classic symptoms are going to be the hot flashes and night sweats and cycle changes. But Kristin always likes to say, when there are no cycle changes, how do you judge that?
Right. Oh, yeah. I mean, we can measure their hormone volume definitely by blood labs, but we know that in perimenopause, it's this time of kind of erratic changes and whatnot. So it's hard to capture. But we do have a brain hormone that starts to tell us kind of hints as to where we are in this menopausal transition. And so looking at follicle stimulating hormone, or FSH, is a great way for even perimenopausal women to sort of see where they're at. Now, over the course of the cycle, the FSH is going to fluctuate, but the studies do show that once we hit 25 and greater, we are headed into, we're, well into that perimenopausal to menopause transition. So that's one way that women can look. And, again, whether you've got an ablation, a hysterectomy with still ovaries, or you've got an IUD, and cycle changes just aren't going to be the benchmark for you. Even if you still have a uterus, we've seen women who are 57 and still cycling regularly. That doesn't mean they're not in perimenopause or not about to become menopausal. And so, getting women to sort of decouple their understanding of menopause as its relationship to the menstrual cycle, I think, is one really important thing that we need to do. Other symptoms, anxiety, sleep loss, cognition changes, and those are common, the hot flashes, et cetera. Those can be the common accepted ones, but it can be so simple as you suddenly have dry eyes all the time, or bone aches. I mean, Maria and I both, we know when our estrogen's low based on joint pain, right? And so there's just other ways. And sometimes we like to argue, like, is that even necessary to know or to identify? And we'd sometimes say no, because what we can feel is only one part of the problem that's happening. There are other imperatives sort of under the hood that are happening. You're never going to feel osteoporosis. You're not feeling plaque deposition. You're not feeling arterial stiffness. And arterial stiffness happens in perimenopause. It's not a postmenopausal issue. So, we can talk about symptoms and things, but we say to women, like, it doesn't actually matter all that much. And we just had a conversation with someone about how the perimenopausal group is sort of like raising their arms and going, but us too, because the discussion's been primarily menopause and postmenopause. And Maria and I are kind of like, yeah, okay, we know you want to be heard, but like, it doesn't matter where you are on the spectrum. If you're a woman with ovaries and a birthday, you're going to be dealing with this. And so you need to just get educated so that you understand what's coming, whether or not you have symptoms.
Yeah. I think one thing that's difficult for me as a practitioner is it's getting its limelight. And so I'll see patients come in and they're like, Doc, I'm in perimenopause. Check my hormones, do something about my hormones. We got to get this fixed. And I'm looking at the patient, like starting to talk to them about their diet and exercise and sleep and stress mitigation. And I'm like, okay, this might be perimenopause, but there's a lot of things to work on here. I know you guys are really passionate about this. So can you talk a little, and you're nutritionists. I mean, you have this background, right? This is like your bread and butter here. So talk to these women who are listening. What can they do from a lifestyle perspective if they really want to take the bull by the horns and optimize themselves through perimenopause and menopause?
Eat protein, lift weights.
No, we didn't plan that with Jamie ahead of time.
No, I didn't plan it, but here's the thing. I mean, I knew that. I still wasn't really practicing it. And when I really practiced it is when it was very life-changing. You know, I still liked, much to Kristin's horror, I still liked my big salads with, maybe a little bit of chicken. I kind of hate chicken now, but it wasn't until I flipped it, like I'll have a side salad, but give me like a big steak or, a big piece of salmon, and it's life-changing. So,
yeah. And what do you like to say, Maria, about HRT being an
optimizer?
An optimizer. It's not, that's these girls who are like, give me the HRT now. We're like, whoa, are you doing all the things, right? Because it's not just about doing all the things before starting hormones because we want you to be disciplined. It's also because whether you're making hormones naturally or taking them, exogenously, it needs a healthy body. So as far as we're concerned, metabolic health has to be a woman's primary pursuit, not HRT. HRT takes it to the next level, but come on, let's start with the low-hanging fruit, the levers that are within your control. And so many women are like, yeah, I got all that, I'm fine. And then Maria and I see a food journal, and we're like, dude, you're not even eating. Like, what is going on? Because usually by the time we get them, they've already had the body comp changes. And so they're leaning into the less is more, thing. Yeah. And so there's so much from, the movement piece. I mean, I get it. And you battle this all the time. I mean, it's intimidating for a woman who's not had gym experience to jump into the gym and start strength training. Totally agree. But so hire someone. There are professionals who make their entire living around working with women to develop better body composition and muscle changes. We have help for that. Work with a nutritionist, understand your macros. Are you even eating enough? Stop fasting, by the way. Please stop your fasting. Or if you're going to fast, do it at night, not in the morning, right? Don't be doing the fasted workouts. So there's basic things like that. Sleep. I mean, Maria and I, are like, get off your phone. And right now is a time of kind of disruption in our, country and stuff. It's very triggering. Stress. Fun fact, ladies, stress is the number one derailer of hormones. So we need to start paying attention to the daily choices that we make and the interventions that we pursue before we start throwing the hormones in the tank.
Yeah, I find that it's just a time in people's life where if they're not doing those basic foundational things, they manifest, symptoms earlier in a bigger way. And sometimes when we go back and fix some of these things, we're like, okay, I don't feel that bad. Maybe it's not perimenopause. Mm-hmm. And I've seen people too who, they're like, I'm definitely, missing cycles, like all the standard, like menopause is happening. And then boom, they just start cycling again. Their ovaries are like, okay, thanks girl. That's what I was doing before.
You fed me.
Yeah, exactly. We take care of our body and it takes care of itself up to a point, obviously. Yeah. And at some point the ovaries will leave the party. They will. So, okay. One thing I saw in your book, which I want to talk about because I don't think that this is commonly talked about, but there's a section called Poop and Hormones or something along those lines and about the microbiome. And oh my gosh, I see women all the time that are like constipated, or maybe they got IBS. Like, can you talk a little bit about what role hormones play kind of just in our gut health kind of during this transition?
Yeah.
There you go for it.
Yeah. Okay. So your gut actually has estrogen receptors. And so when we lose that signal, right, and your gut your estrogen helps with motility. Right. So again, when that estrogen is in decline, constipation is very common in women of menopausal age. So we've got that. And then we are losing the liver as well, which is part of the whole gut health cascade is also losing estrogen, and it's going to suffer as well. So
We have that. We've got kind of a two-way relationship between the gut microbiome. So our basket of bacteria that's in the gut is highly dependent upon estrogen signaling. And so as we lose that estrogen signal, we lose the diversity and we lose the abundance of that gut microbiome. That's going to lead to changes in our mucosal lining. We see food intolerances common. We see neurotransmitter production issues at this point. So a lot of mood issues that are driven by gut changes. Autoimmune concerns start to come up. And then we also have changes in our digestion, which is a huge downstream issue because parietal cell function in the stomach also is dependent upon robust estrogen. Parietal cells release all our gastric juices. That's the first kind of chemical kickoff we get to breaking down our nutrients. So you could be eating the most perfect diet in the world or nutrition plan, but if you're not absorbing those nutrients because you can't cleave them out due to this lack of estrogen, which downregulates digestion, not only are you going to be nutritionally deficient, but now you've got these kind of larger, too large molecules dropping into the small intestine and causing some problems as they try and move through a system that's used to them being broken down. So it's this huge cascade that really happens. And, estrogen needs to be excreted. We talk all the time. People who do Dutch tests will talk about phase 1 and phase 2 detox and metabolism of estrogen, but we have a phase 3, and that's pooping and peeing it out. And when we don't poop, we can usually see an increase in an enzyme called beta glucuronidase, which essentially unpacks these beautiful packages to be excreted and lets them run wild again. We can reactivate estrogens, cause recirculation. And this is where a lot of women who, even though they're low estrogen production, will feel estrogen dominant because they're recirculating their estrogen due to failure to poop. So there's so much going on with the gut and estrogen and digestion that then translates into full metabolic health. And, we know disruptions in the gut microbiome increase breast cancer risk. There's so many things that happen because of this loss of estrogen and its crosstalk with the gut microbiome.
Yeah, it's fascinating. I think people are always surprised where we have estrogen receptors.
Yeah.
I think people think it's just like they're, in their breast,
Lady
in their
part.
ovary, in their uterus. No, they're like in your ear and in your brain and in your colon. And it's pretty incredible. This might be TMI, but there's no TMI when you're a gynecologist, right? So I would describe my bowels as like slower most of my life. But if I were to track a Bristol stool chart or just like stool frequency throughout my menstrual cycle, like during follicular phase, it's like boom, like every day, like super regular. Then I get to luteal phase and it spreads out to like every other day. And during that high progesterone, it just slows my gut down like incredibly. And I actually feel better with less fiber, and we can go back to nutrition.
Oh, we're with you on that.
I just feel better with less fiber. But it's so interesting to me when women have bowel complaints. I'm like, have you ever tracked your bowels with your menstrual cycle? Yeah. They're like, no, I've never done that. And then they start to look at it and they're like, oh, interesting. Like I have kind of like loose stools when I'm on my period, and then it's like really good. And then I get to luteal phase and it's like really slow. And it's your hormones. It's the impact of the hormones.
Yeah. And women will see that same impact with HRT. So if you choose to take your hormones in a way that mimics the cycle, meaning you're cycling your progesterone, a lot of perimenopausal women are doing that, and they should be because they're still cycling. We choose as postmenopausal women to do it that way. But we will have women who be like, I hate progesterone because I never poop on it. And we're like, fun fact, you did that probably when you were cycling and you never connected the two, right? Mm-hmm. And so we tell women all the time, like, if you're younger and listening to this, use an app like Clue or something and start tracking these things. Not just your bleed, right? Track like your breast tenderness, track your mood swings, track your sleep architecture, track your pooping, track your headaches, track all these things. And women start to be like, oh, this is all related to these things, and I think we kind of overlook that part when we're younger.
Yeah, and about progesterone, that's actually why, even as much as we educate about hormones, that's why one of the reasons why we're not fans of women just taking progesterone as a supplement or, it's over the counter transdermal in the USA and slapping themselves on with progesterone, because again, they can have these things happen, and the high progesterone, is not necessarily a good thing. Like you just mentioned one thing, you have a bowel slowdown. So can you imagine women who are already struggling with that, but they think that they need progesterone because they're estrogen dominant. So they go into these very large Facebook groups that are all focused on progesterone and estrogen dominance, and they start loading themselves up. So Kristin and I always do say, hormones are amazing, but they're not DIY. You need to be working with a practitioner.
Yeah.
Mm-hmm. Yeah. No, they're a powerful tool and they need to be used correctly. Talk to us about, we're seeing on social media, HRT, MHT, medical hormone therapy, hormone replacement therapy. Are they interchangeable? What are those things? Tell us, for our Instagram people, how do they read through the lines there?
That's all you, girlfriend.
I get fired up on this topic. Okay, so MHT stands for menopausal hormone therapy. We have HRT, hormone replacement therapy, and BHRT, bioidentical hormone replacement therapy. So one of the biggest differences with MHT and both of the others is that it is primarily, it's a term coined by the North American Menopause Society, and it is primarily telling you what your physician's focus is, and that is symptom suppression. So MHT takes the approach of any type of hormone or hormone product. Unfortunately, birth control pill for a lot of MHT providers is acceptable to them. We don't see it that way. So MHT is going to be for symptoms, usually a narrow list of them, vasomotor symptoms or hot flashes, and then diagnosed osteoporosis to address those, and then shortest duration, which doesn't always make a ton of sense, because if you have a woman who has diagnosed osteopenia and she's worried about progression and you give her hormone therapy and then you tell her, we'll use this until it stops, well, ideally there is going to be a halt in progression. But once you remove then the hormone therapy, you're probably going to kickstart that process again. So MHT doesn't make a lot of sense to us because it's a very narrow kind of view of the power of hormones and why you would use them. HRT technically could be encompassing any sort of hormone usage. I mean, my son had a growth hormone deficiency for a while, so technically he was using HRT. Birth control could be considered HRT. Transgender care could be considered HRT. In the context of menopause in women, HRT is essentially just that, hormone replacement therapy. It doesn't tell you much, though, because you don't know if the person is using it for long-term disease protection, this narrow scope, or whatnot. Where the B started to get added to that was because there was a difference in doctors of the type of estrogen that they were using. And so bioidentical hormone replacement therapy sort of became the darling to differentiate HRT usage that included things like the birth control pill or even an IUD, to be perfectly honest, from those who were using things like molecularly mimicking molecules that resembled or were identical in structure to our ovarian produced hormones. There are a lot of physicians who still like to kind of repeat the trope that bioidentical is a marketing term. Whether it developed that way or not, I think is totally irrelevant. What it is it's a sign that someone's saying, I'm using 17 beta estradiol that molecularly identifies to your ovarian produced estrogen. So I don't think that women need to be all that worried about BHRT versus HRT with most providers, because it's almost not common or at all normal to see people using synthetic forms of hormone replacement therapy these days. Do you sometimes see?
No.
I know. But I'm saying, if you have a provider out there who says they're using HRT, just ask them what form of estrogen. Don't completely dismiss them simply because they didn't use the B in front of HRT.
I would say the vast majority of women, I do see them taking 17 beta estradiol, but I still will get patients sent to me who are taking medroxyprogesterone acetate. And I think a lot of it, when you, like in my electronic medical record, when I type in, Prometrium, which is, micronized natural progesterone, it will sometimes give a formulary interchange that says like, well, medroxyprogesterone acetate is number 1 on the formulary. And so I think sometimes people without good education are like, okay, well, that's $4. That's cheaper. Let's just, use that. And NAMS, the North American Menopause Society, and other people, still offer these other progestins. And we definitely need to have a conversation about that. But, so for people listening, if you want to take natural bioidentical hormones, you can get them in pharmaceutical grade in a prescription. They don't have to come from a compounding pharmacy or anything like that. And so, make sure you're taking 17 beta estradiol. And if you're taking progesterone, take micronized progesterone. It comes as Prometrium, or it comes in generic as well. And there's lots of formulations. There's pills and gels and creams and patches and lots
injections
of ways to deliver the same hormone, but they are the same hormone. Now there are nuances in the dosing of, whether you take it orally or through the skin, and we can go into those too, but just for people to kind of understand really medical hormone therapy, hormone replacement therapy. Some people use them interchangeably. Obviously, there's some nuance involved. Back to the NAMS thing for a second. So for the people listening, I am board certified from NAMS, North American Menopause Society. Kristin and Maria sometimes on social media, they're get into arguments. Yeah, maybe it's like the evil empire. But I think what people need to understand is, as a practitioner, I might be a board certified OBGYN and not necessarily agree with everything that ACOG says. I'm an individual. I get to use my brain and my expertise, and I treat patients all day. And that's where you learn the most, is by, treating patients. And so I'm board certified. I think for you, Kristin and Maria, the one thing I do think that is really great is it has brought a lot of patients to me and allowed me to treat a lot more patients that would have never otherwise sought care. There's just not a lot of providers out there yet. There's a lot more. And I've seen a lot of my colleagues wanting to learn more. And so it's finding, I think it's still helping us move in the right direction of, opening the conversation for patients and for providers. So
yeah, we don't disagree at all with that. I mean, if it's a way for people to start an education, but you've had a different lens on this for a long, long time. And I think, for better, for worse, this business of menopause that has sort of boomed recently is that we're getting providers who aren't even necessarily trained in women's health, who can go through a NAM certification and then they hang their shingle. And we just don't want women to assume that that is a rubber stamp for skilled and nuanced HRT provision. And that's, I think, the problem that we're seeing is too often it's sort of used as like the gold standard. And we're saying, look, it's doing things that are good, but it's not necessarily the gold standard. And this is where women have to ask their doctor questions, right? I mean, I hope women are interviewing their provider a little bit, but that would require the woman to have some knowledge and education first before they go into that meeting.
Oh, I've seen train wrecks in my clinic coming from these little, pop-up hormone clinics. And there's, I went to this conference one time and was getting some, education. And I mean, there was like a guy who's stepping back from radiology and orthopedics, and I'm just going to open a med spa and do hormones. And I'm like, you want the guy that fixes femurs messing with your estrogen? Like, what is going
Dermatologists, I mean, not to put them down, but we see it all the time. We had someone who was on a call with us. It was a teaching call, and it was an ophthalmologist. And I was like, you know what? Yay, you for being interested in this. I love it. But really, are you the right person to be doing this? Because I'm just not seeing, kind of a holistic approach when we're just talking about a drive-through, certification sort of thing.
Well, I mean, if they get training, they certainly can be. But I think the issue is, again, I think, Jamie, you kind of alluded to it before. There is just a huge menopause boom right now.
Yeah.
There is. It's a $1 billion industry.
It is. Well, and I have to say one quick thing about your progestin comment, because just this morning I saw this social media post by very well-meaning folks who have a very huge book on estrogen. And they were talking about the WHI, and they said, we look at the progesterone used by the WHI. And I was like, no. It was progestin. And and this is where I think women need to understand that there is an umbrella term. Like even estrogen is an umbrella term, right? There's no...
Well, to unpack that, Kristin, I mean, tell people, what is the difference between progestin and progesterone?
Yeah, so progesterone is going to mimic, again, look at the ovarian hormone that you were producing and has the same molecular structure. Progestin is a synthetic. It's a drug. It's not a hormone. It can signal at the receptor for progesterone. Unfortunately, it's an endocrine disruptor. And so it alters the progesterone receptor. It also alters the estrogen receptor. And so through its endocrine disruption, it results in folded proteins, and it actually raises cancer risk because of DNA modification. So there is an umbrella term called progestogens. And then we have underneath that progesterone, which is natural and bioidentical. And we have these progestins with their synthetic drugs and endocrine disruptors. And those are the nuances that I think sometimes Maria and I are kind of always trying to fight back against and say, wait, you got so close, but you missed, because we need to use the right terms, because women aren't realizing that there are these distinctions. And so they may end up with, I think, what is it? Is it Bijuva, Maria? That's an oral estrogen combined with an MPA, a synthetic. We're like, oh, you got so close. You gave them 17 beta estradiol, but then you messed it up with the progestin. So That's why we constantly are trying to kind of stir the pot a little bit to bring this nuance to women's psyche so that they're like, whoa, wait a minute, I actually have to pay attention and make sure that the right terms are being used, because then I can make sure I'm getting the right hormones.
Yeah. So for people listening, birth control pills are all going to contain some different kind of progestin, norethindrone acetate, levonorgestrel, etonogestrel, desogestrel, they go on and on. When it comes to hormone replacement therapy, there's only one progesterone,
Yes.
Prometrium micronized progesterone.
Yes.
It does come in a generic. You can get it from the pharmacy. It doesn't have to be compounded, but it can. So that's the story there. And yes, talk about the breast cancer. She, mentioned the cancer risk in the studies where there was an increased risk of breast cancer. It was the patients taking estrogen and a progestin. It has not been shown with progesterone. And progesterone is actually anti-proliferative. That's why we give it to protect the endometrial lining of the uterus. So it protects from uterine cancer, and there's not an increased risk of breast cancer that we've seen. So
yeah,
that's something very important for people to know. But let's stay on this progesterone for just a second, because earlier you were talking about cycling versus continuous, and you guys have, a way that you like to do it. Can you dive back into, because you've got a nice section in the book, the various ways of systemic hormone therapy and dosing. Can you unpack that for us?
Well, we know that this is this could be controversial, and if you want to push back on us, we're here for it. Where you don't have to fully agree with us on everything, but we like the idea of cycling progesterone. We're trying to mimic nature, and at the end of the day, we're trying to maintain receptor sensitivity so a woman can have her hormones work for her and not stop working. Like we hear from a lot of women who say, I started HRT, but it didn't work for me. It stopped working. So we think maintaining the receptors by cycling the progesterone is the effective way to do that. The problem is that if you have estradiol and you are building the lining of the uterus, when you take away that progesterone, the uterine lining is going to shed. And some women don't like that. And from what we've seen, many doctors don't like it. Not all. We have, 24 or so doctors that we work with that are like totally fine with managing that. And it is more management. Like it does require more management. It requires the woman to be okay with that. It requires the doctor to track it, to make sure that it's, it's not painful, it's not crampy, it's not flooding. There's a problem if that's the case.
Yeah. And I think the other thing is, we have a chart in there that just shows the women what their cycle was when they were producing their hormones naturally. And we put that in there. I mean, anyone can go on Google and find it, but we put that in there simply because there are physiologic processes that are being triggered by that rhythmic presentation of the hormones. So it's not just having progesterone. And yes, the receptors need some sort of, downregulation or lack of stimulation in order to stay fresh. But at the same time, that progesterone kicking in when it does in the natural cycle is biologically relevant. And that's what a lot of women don't understand. And I think if we taught girls this, I mean, like I look at your girls, I'm like, can't you just wait until they're cycling and you want to teach them all about it? Because the cycle is so cool and it has very little to do with fertility when you look at the global part of a woman's health. And this change in estrogen peaking and then coming down and progesterone kicking in has so much to do with cancer protection. We know that P53 tumor stimulation is very relevantly driven by the progesterone coming on board when it does. Many more things could be added to that list. But the point is, if women understood that this sort of relationship and this beautiful dance between our hormones during our premenstrual years was relevant to our whole body health, then maybe they would see the way that they administer hormones slightly different as well. And there's plenty of doctors out there who says, okay, yep, I can get off on cycling progesterone for the perimenopausal woman who's still cycling because we don't want to disrupt that feedback loop of her endocrine ovarian cycle. But again, that's they're focusing on cycle changes there, right? They're focusing on like continuous, it wouldn't be good because we could disrupt her cycle. But Marie and I are like, wait, take the cycle out of it, or at least put it down the list a little bit, because the other things that are happening from that progesterone kicking in when it does and having its presentation as it does control our health. And, you know, from angiotensin and our arterial stiffness, I mean, there's so many things that are relevant to that. So that's partly why we're fans of cycling, is because if it was okay when we were younger, and let's face it, the body's really freaking smart. It does things for a reason, right? I think we can all agree with that. So why wouldn't we then continue the body's rationale and just accept that it knows what it was doing and do that as women age as well?
Yeah. I'm not going to say I disagree with anything you just said, but I want to have like an open conversation about it. So I think as somebody who sees women and prescribes hormones, a few things. So the perimenopausal people, I do like to cycle it in them, but sometimes their cycle is so wonky that they don't even know, okay, I'm supposed to take this cycle age 14 through 28. But I mean, like, you know, their cycle's so crazy that they just have so much difficulty with it. And so we're like, okay, let's just try and take it continuously. There are some people that are sensitive to that fluctuation too. I've seen some women who like it for like the anti-anxiety and sleep benefit, and they, you know, decide that they like to take it continuously. I think it's a very individualized approach. Some patients feel better one way, some patients feel better the other way. With the bleeding thing, I find sometimes we'll uncover with hormone replacement therapy that a patient had fibroids or polyps or whatever it is. And that's why the OBGYNs can get a little bit like, okay, well, now I got an ultrasound and now I got to do an endometrial biopsy. And is this just from I would say in patients who are even taking continuous hormone therapy, about 30% of them will have bleeding, you know, even if they're just taking like continuous hormone replacement therapy. And in the first 3 months, that's usually not a concern. But in patients who are technically postmenopausal, even when they're on HRT and they're having bleeding, you do an ultrasound, look at the endometrial lining. If it's less than 4 millimeters, it's just from the HRT. There's no reason to even do a biopsy. But sometimes you'll, you know, see things. Now, let's see if I can even hold this up. I wish I could. Okay, people can see that, right?
Yeah.
Okay, so what Kristin was talking about was, you know, if you look at this, if you Google image, what happens with my hormones on my menstrual cycle, you'll see the estrogen and the progesterone kind of peaking at different parts of the cycle. And so this is cyclic progesterone here. So it's doing kind of the same thing that it was doing with the menstrual cycle. Now you could make the argument though, Kristin, if estrogen does that too. And so I think, you know, it's like we could really play, you know, like ovary master.
Yeah.
I mean, but this is like way too complicated for patients, you know, like they don't, like my girls in my office are like, I mean, they would love like if I could just wrap this into like one weekly thing and just like throw it at them. I mean, it's so much, some of these women are like busy, they still got kids at home or they, you know, corporate careers, and like just the thought of like a twice weekly patch and oral progesterone 14 on 14 off is like, lady, like, don't you have something more simple than that?
I think the reminders.
So, I mean, I think it's for. I think for some people, you know, it just, you got to figure out, you know, like how to meet the patient where they're at and what they're willing to do and what their goals are. And
we don't disagree. I think the biggest thing for us is that too many doctors are making that decision for women instead of having a discussion with them about it. Right. And
I would agree with that.
Yeah. We know that there's a Danish study that shows that the women who used continuous had higher cardiovascular disease risk and changes and poorer outcomes with heart health than the women who were taking it cyclic. So, you know, I think as long as that discussion is had, we know that tau protein clearance is dependent upon that cyclic presentation of progesterone. So that piece, I think, is really important. And what you pointed out, we know that there is a huge percentage of women, as far as I'm concerned, 30% is large for women to have unscheduled, unmanaged bleeds. Like that can freak a woman out and expose her to DNCs of some doctors and et cetera. So our attitude is just let the woman decide, but give her all the facts, right? And I think sometimes the facts are being concealed because doctors are like, I really don't want to deal with this, you know, or like, that's great. That's your choice. But, you know, if a woman understood that maybe cognitive changes in heart could be optimized by cycling it, you know, that would be an option for them. And there's a lot of women who are like, look, I had a history of endo and fibroids. How about we take my uterus out and then I'm going to cycle my progesterone? And that's a common stance for a lot of women and perfectly reasonable.
Yeah, no, I've had a handful of women who just like bleeding and then it stops and then they're bleeding again and they're just tired of doing ultrasounds and figuring it out. And they're like, dude, I feel good on my hormones. Just take out my uterus and we're just going to like, and it does simplify it. Now, you know, obviously like nobody wants to sign themselves up for a surgery, but it is sometimes a situation where patients will elect to do that. And these days, surgery is such minimally invasive. I mean, I do it outpatient. They come in at 7 a.m., they're home by noon. Many of them are back to work within a week or two. So it is way better than it used to be. If you have a normal size uterus and can get away with like a vaginal hysterectomy or something like that. So, but let's talk about people who don't have a uterus. So you've had a hysterectomy, or you choose to have a hysterectomy, or whatever it was, and you don't have a uterus. And then your doctor says, well, you don't even have to take progesterone. This is very easy. You can take estrogen only. Go back to that conversation on progesterone. Should people who've had a hysterectomy consider progesterone therapy, or do they just not need it?
I would say in most cases, yes, they would benefit from progesterone therapy. We do find, I'm sure you see this as well, just progesterone sensitivity, where women just, for whatever reason, it makes them weepy, it makes them depressed, it makes them tired. Maybe they are, if they just cannot figure that out, okay, so they don't need it. But we still think that the hormones do work kind of in relationship to each other. So we do think, it is good even for women who have a hysterectomy. Again, the breast health, the little bit of the interplay on the bone health, brain health. So yeah, we are fans of women who, even though they've had a hysterectomy, to have some progesterone.
Yeah, I think,
and then it makes 2 weeks on, 2 weeks off a non-issue.
Oh, so easy.
Oh my gosh. We're always, anytime we get a woman who's had a hysterectomy, we're like, oh, you hit the lottery. This is going to be great for HRT.
Yeah.
But yeah, I mean, I think we forget that we talk about estrogen receptors lining a woman's body, but we have progesterone receptors all over different places as well. And so again, if we go back to everyone admitting that the reason why we cycled these things and had this beautiful presentation when we were younger was because it was this catalyst for different actions, don't we want to maintain the actions of progesterone as well? And brain health is one of the bigger ones. I will say one thing is that we also know that day 12 peak of estradiol is relevant in producing progesterone receptors over the course of the cycle. And so that's something that a lot of doctors kind of overlook, is that we need to have a robust enough presentation of estrogen to have the progesterone receptors so that a woman can utilize the progesterone when she takes it. How this can manifest is someone on a really, really, really low dose patch. She'll be put on like 0.025 or even the 0.0125. And then she got sleep problems. So that doctor's going to give her like 300 milligrams of progesterone or something just to flat out sedate her at night. And it may work in the beginning, but she ultimately will develop like the breast tenderness and the mood dysregulation and maybe even a reversal of the sleep issues to be back to being insomniac. And that frequently can because we need that estrogen level to be high enough to create those progesterone receptors. So this again is why I think picking the right provider is so key, because these are little nuances that need to be understood by the person writing the prescription. And unfortunately, too many people with a prescription pad are now dosing out hormones with, very little understanding of those things.
Let's go back to the estrogen for a second. I find women who will come to me on, compounded formulations of Biest. So estradiol and estriol, or I've seen all sorts of combinations, 50-50, 80-20, all these different things. Can you unpack for the listeners just a little bit the differences in these natural estrogens and what might be most optimal?
Yeah. Oh, I've got feedback too. I'm not sure what's going on. Can you hear me okay?
You sound great.
Okay, good. So essentially, we do have 3 different estrogens primarily. We have others that we are now kind of starting to discover. I think E4 is a new one that's come out. But primarily we have estrone, and women can think about it that as E1, because in the word it says O-N-E at the end of it. So estrone, estradiol, so the DI for 2, frequently you'll see it as E2, and then estriol, which is the tri, E3. Each one of them act differently in the body, and what we produce ovarian is typically estradiol. There are some of each of the others. Estriol is primarily a hormone and estrogen of pregnancy. We know that estrone tends to stimulate the alpha receptor, and estriol tends to stimulate what's called the beta receptor. So think alpha like accelerator and beta like brake. And so we can have more growth with estrone and a harder stop with the estriol. Estradiol actually has a very balanced effect. It stimulates both receptors. And that's really important for all those physiologic processes in the body, because alpha and beta, they aren't necessarily bad or, better compared to one another. It's just we need a balanced presentation of them. So you've seen Biest. We recently, like literally in the last, 10 days, Maria, we saw someone with Triest, which meant she had all three in it. And we were like, wow, that stopped years ago. Who's still dosing that? Yeah. But essentially Biest is a cocktail, and it's a combination of estriol with estradiol. We like to refer to it as sort of the two-footed driver, because if you've got estriol combined with estradiol, you've got more feet on the brakes than you do on the accelerator. And so you've got this kind of start-stop thing that's a little bit, if you've ever driven behind someone with their brake lights on while they're accelerating, you're like, I don't know what to do here. And that's part of the problem with Biest, is that estriol can sort of knock estradiol off the receptor and become the dominant estrogen. And why that's a problem, as I alluded to, it is the predominant hormone of pregnancy. And we know that in pregnancy, we have sort of this reduced milieu of the immune system. And that is specifically so that we don't reject the DNA of the sperm during fetal contraception and whatnot. So that part of it is concerning, in that we will downregulate a woman's immune system when we're taking too much estriol. In addition, we're not getting the things that estradiol stimulates because of that knockoff of the receptor. There's some very prominent docs out there who like to push and say, but it's breast protective because women who are pregnant don't get breast cancer. Well, that's not entirely true. There are plenty of women who get breast cancer during pregnancy.
And it grows.
Yeah,
fast.
Exactly. And the other issue is that the study that they're looking at really had six pregnant women who had higher presentations of estriol in their urine metabolites, and they didn't get breast cancer. And so that's where this conclusion was, that it was breast protective. The problem is estradiol is also breast protective, but in addition, estradiol can convert to estriol as the body needs it. And so when we go back to this urine study, it's like, who's to say that we didn't see all this estriol because estradiol had converted due to the pregnancy, right? So to demonize estradiol, or to suggest that it's unsafe and that estriol is quote unquote safer, is just not really based on science. And when we look at the highest levels during the follicular and luteal phase, it's estradiol. That is the predominant estrogen that women should be concerned about. So we're not huge fans of it. And to be perfectly honest, we see women coming in with osteoporosis who've been on Biest for 10 years. And, combine that or compare that to a woman on estradiol who's maintaining her bones. There really isn't a lot of debate as far as we're concerned as to which estrogen a woman should be taking.
Yeah. I'm starting to see more women with coming in using topical estriol on their face. Or I had a gal who moved from out of state that was doing some vaginal estriol, and I was like, why don't we just use some estradiol? Yeah. But I'm not seeing it as much. But for women listening, I want you to understand that. And there's actually more than 3 estrogens. There's a new birth control out that contains estetrol, which is E4. Which is also primarily a pregnancy hormone. But if you go back and look at Premarin and conjugated equine estrogens, they contain a ton of different estrogens, and it comes from horse urine. So there's probably a whole load of estrogens we don't even talk about in humans. But let's shift for just a couple of minutes to finish this out. Testosterone. Do you guys have an opinion? Of course, we've talked all about estrogen and progesterone for women, but what role does testosterone play in perimenopause and menopause?
Yeah, we're fans of testosterone at the for women that need it and that women that can benefit from it. I tested my mom's hormones. It was a few years ago, but she's in her 70s and she had a pretty good supply of testosterone still. I was kind of amazed. Wondering if you see that in older women as well sometimes.
Yeah, I mean, the postmenopausal ovary and adrenal glands, I mean, we see testosterone production, and I don't always see low levels in these people, not like I do with their estradiol levels. With this whole over-medicalization, we could say that maybe like more women are getting testosterone than necessarily need it. But I do think it's good to optimize it, especially from a age-related sarcopenia standpoint, because it's anabolic to the muscle and to the bone. So I think when we think about, these like frail little ladies, some of them could benefit from optimization of that. The tough part is like, we just don't have a ton of data on testosterone in women. It's just not been well studied. What's the optimal range?
Right.
And vast majority of the time, I see these people come from other clinics with super therapeutic levels of testosterone.
That's our
like
issue.
200, 300. I've seen women walk in with an 800. And that is transgender therapy. I mean, you are literally like, that is what you give people to transition into a man.
Yeah.
And so you've got to be careful. They'll get clitoromegaly, they'll get acne, they'll get hair growth, they'll get hair loss. The side effects of over prescription of testosterone is not things that women want. So I think you have to be really cautious there. The tough part is, like I said, it's not FDA approved for women. So you always have to use a compounded, or we can use, I've started to use just prescription testosterone and tell the women how to do the, dosages if they're doing it. I think it's getting a conversation in the sexual health world because hypoactive sexual desire disorder, I think, is more prevalent than people realize. But I find it's 50-50. I find for some women, we put them on a little bit of testosterone and it helps libido. For a lot of them, it doesn't. And that's because in women, that's a whole nother podcast. And I have other podcasts on that. But it's a whole different, it's not just testosterone. It's estrogen. It's not vaginal dryness. It's not having metabolic disease. You gotta have good blood flow. Nerve endings gotta work. Like, it's not just like, give them TRT and they're going to be humping their partner. Yeah.
Well, a lot of the women will say it's the super physiologic doses that actually will stimulate their libido. And you frequently see that with like the pellet ladies, right? That they just got these whoppers of libido, and like, that's great, but your voice box is changing and that's not going to be reversible, even if we can change the hair loss and maybe, surgically repair your clitoris kind of thing. So, and your point of that not being FDA approved is so important, because women are like, but why is my doctor giving it to you? And frequently they're giving the vials that are made for TRT for men. And then they're having these women sort of try and microdose them if they're thoughtful physicians. Otherwise, some of them are just giving them dosing that's really off the charts. And, testosterone is highest in volume of all the hormones. We hear that now. That's kind of, Maria loves say it's common trope. And it's unfortunate because women are like, testosterone's my thing. And it's like, but testosterone's sort of one link in the chain. And we do really actually depend on estrogen. And you can't rely that if you take testosterone, it's going to convert into estrogen for you. And so, why not just take your estradiol? And I think the premenopausal women and maybe early perimenopausal women who are saying it changed my life. And I'm like, that's probably because you had some adrenal issues, and we're kind of covering up the root cause of what's going on in a lot of these women. So with postmenopausal women or late peri, if you start testosterone first, you need to understand that it can sort of block part of your estradiol uptake, because it does share a receptor cell wall with estradiol, which means up to a third of your estradiol is being blocked. So Maria and I are like, hey, let's start with the ones that we know are really important for our health, estradiol and progesterone, and then add in testosterone if you truly need it. But newsflash, let's also work on our metabolic health at the same time, because you might be surprised that energy and vitality and sexual drive that you were lacking comes back when you've got estrogen and good metabolic health.
Yeah. I mean, when you look at the literature, there's something to the testosterone estradiol ratio, and our estradiol is made from testosterone. And so I think there's a role for it. And I think that hopefully we'll, have more data and better guidelines and hopefully FDA approval so that people can, start giving it in a more normal way. So, I mean, you think if Big Pharma wants to make money, they would go ahead and just, fund some studies so that they can get some female versions out there, since this is $1 billion industry. But in the meantime, they're giving the compounding pharmacies a lot of business.
Yeah.
So, yeah. Well, Kristin, Maria, tell people where they can find your book, where they can find you, where they can find your work. Maybe they want to work with you.
Oh, so book is on Amazon, Barnes & Noble, independent booksellers, comes out on September 10th. And after that, about a week after that in the UK. Thank you. And they can find us on Instagram at Wise and Well. And our website is wiseandwell.me. Thank you.
Thank you guys so much for what you're doing and helping further the conversation for women. I'm glad it's getting its limelight, and I hope this conversation doesn't slow down. So thank you guys so much for what you do. Well, go give Kristin and Maria a follow, Wise and Well. Check out their new book. I got an advanced copy way before all of you, The Great Menopause Myth. It's fantastic. And honestly, it's very easy to read. It's laid out in a way that I think, doesn't complicate it too much for people, which I know menopause and perimenopause feels very complicated. Okay, ladies, most days. So thank you guys for listening. Make sure you share this with all your girlfriends and your guy friends, because I think they need to understand what's going on with the women in their lives. So we'll catch you all in the next episode. Have a good day.
Did you guys love that last episode of the Fit and Fabulous podcast? Well, of course you did. And I want to keep bringing you the most amazing content from the most incredible people. And you can help me by subscribing to the Dr. Fit and Fabulous channel. You guys know where the button is. Just click it. It's the doctor's orders.